Thank you all for joining us for the Oley Foundation webinar, Treatment Options for Gastroparesis. My name is Rosalind Dahl. I'm the Communications and Development Director for the Oley Foundation. Most of you are probably familiar with the Oley Foundation, but just in case this is your first experience, I'd like to briefly introduce the organization. The Oley Foundation strives to enrich the lives of those living with home nutrition support, both intravenous nutrition, sometimes called HPN or TPN, and tube feeding. We do this through education, outreach, and networking. The Oley Foundation was founded in 1983 by Dr. Lynn Howard and her patient Clarence Oley Oldenburg. Today we serve a little over 17,000 members. All of our programs are free of charge for patients and their families. First, I have a few housekeeping details for today's webinar. In the upper right-hand corner of your screen, you should see a toolbar. If you're not seeing the full setup there, click on the orange arrow. In the questions section of the tool panel, you can type in any questions you have for me or for the presenter. Please note we will not be responding to the hand-raising function in the control panel. We will answer as many of the questions as possible during the questions and answers period at the end of the presentation. We'll post a recording of the presentation and the slides after the webinar is finished on the Oley website at oley.org/webinars. We've muted all of the participants, so you don't need to worry if there's any background noise where you are taking this webinar. If you are experiencing any technical issues on your end, please go to the Citrix website at the address on your screen. It's right here in the middle, help.citrix.com/webinar/join. In today's presentation, Dr. Abell will discuss his 35 years of experience with patients with the symptoms of gastroparesis. Much of the talk will concern the perspective gained from 100 patient focus groups over the last 25 years. The published work on the National Institute of Health Gastroparesis Consortium will be discussed, as well as current thoughts on the pathophysiology of gastroparesis and the gastroparesis-like syndrome. The presentation will end with a review of therapeutic options for these disorders. Now, it gives me great pleasure to introduce today's presenter, Dr. Thomas L. Abell. Dr. Abell is a gastroenterologist who has specialized in GI motility disorders. He has been in the American Mid-South for 30 years now and is the Arthur M. Schoen Chair in Gastroenterology at the University of Louisville. He is interested in all aspects of gastrointestinal motility, but especially the treatment of nausea and vomiting with low energy and high frequency electrical stimulation, which his team in Memphis pioneered. Dr. Abell has developed the endoscopic implantation of GI neuromodulation devices and applied electrical mapping to the GI tract. His current work is funded primarily by the National Institute of Health's Gastroparesis Clinical Research Consortium and NIH's DIACOMP studies, as well as ongoing work with industry. Dr. Abell is particularly interested in the pathophysiology of the gastroparesis syndromes, as well as predictors of the response to electrical stimulation, whether low or high energy devices, and their mechanism of action throughout the body. We are thankful to have you with us here today, Dr. Abell, and I will now turn the presentation over to you.
Hello, I hope you can hear me okay.
Yep.
And I'm going to, just a minute here, start the slides. I have about 40 slides, so probably about 40 minutes, and then time for talking and trying to answer questions. And as I'll say at the end, we'll also try to answer any other questions that we can't answer on the webinar. I'm going to just go through the slides here. One question is I'm having a little trouble advancing, but there we go. Okay. I want to give my disclosures, which is important for any audience. My primary funding, as you just heard, was from the NIH. I'm also an investigator for a number of companies that are working with drugs development for gastroparesis, and a consultant for one of those. I'm also an editor for MedStudy, which is a review system for trainees, Neuromodulation, which is a journal, and WikiStem, which is a database, and a reviewer for UpToDate, and have some intellectual property from the University of Mississippi, where I was before. And I'm going to certainly discuss off-label drugs and devices. The organization would be first some introduction and personal statements, and then what I see is the current status of patients with gastroparesis and gastroparesis-like disorders. I'm going to talk about my perspective on the NIH, FDA, and Medicare involvement, and the pathophysiology of the syndromes. The talk will end with the discussion of the options for treatment of gastroparesis, which is really the title of the talk, and talk about discussion of team-related care and some concluding comments. From a personal perspective, I'm 69 years old. I've been actually working on this area for 35 years professionally, but about 50 years, because I started working on this in college. As I'll tell you in a minute, over 50 years, I would say it's gone from bad to good to mixed to now to the future. And I got interested in migraine-related nausea, vomiting, which I had a number of people in my family with migraine. And I was told when I was in college that these were all psychosomatic, which intrigued me, wondering how the mind could do this. Of course, it turns out they're not psychosomatic, they're biologic, but that's part of my saga. So the presentation today is going to be just my own opinions, nobody else, not the University of Louisville, the NIH, or any support group, just my opinions. So the symptoms of gastroparesis are, as listed below, common symptoms I've put an asterisk there: nausea, vomiting, abdominal pain. But patients also have bloating, distension, loss of appetite that we call anorexia, and may have many other symptoms. For example, many patients have lower GI symptoms like constipation and diarrhea. Some have, unfortunately, have fecal incontinence, may have urinary symptoms, hesitancy or urinary frequency, and some people even have an immune disorder called interstitial cystitis. Then there are other symptoms. Many people have autonomic nervous system things like dizziness or fainting or cold intolerance or heat intolerance, and many have migraine headaches, one of my particular interests. Others have been diagnosed with disorders of muscle called fibromyalgia, and some have autoimmune diseases. Many have overly flexible joints. Many have a cyclic pattern, different than cyclic vomiting, which is a classic disorder. Some people just have days or weeks that they're much better than others, and sometimes it's a regular or irregular cycle. Some people have family history. Other people have seizures or other neurologic disorders. So with all these variety of symptoms, the question I think is obvious is, what are these all from? You can, for example, have an acute illness, such as a viral infection, and just about every human in the world has had a viral infection with nausea, vomiting that resolves. Some people have recurrent or chronic symptoms and have the diagnosis of gastroparesis. Unfortunately, most providers, including myself, never learned about gastroparesis in school, training, or practice, and thus they may not value these symptoms, tend to dismiss them, or they may not value the illness and thus the patients or the doctors that try to take care of them. And I'll talk about that. I'm going to talk about what I call the history of patients with gastroparesis. I list as I like abbreviations. So the M's are the misses: miserable, misunderstood, misdiagnosed, mismanaged, and mistreated. I know those are pretty strong words, but as I'll tell you in a minute, these are based on the last 35 years of seeing literally thousands of patients. Hopefully these days are behind us or almost past us. What I've learned, I'd like to talk about on history, as I mentioned above. We also had about 100 focus groups over the last 25 years with patients. And one of the things I learned was how little we've actually known about gastroparesis and how much patients are trying to tell us. And additionally, how much suffering, which is called the disease burden, exists. And sadly, this is the history of much in medicine. if you're interested, like I am, about how illnesses were described, gastroparesis is a good example. I'm going to show only a couple of illustrations. This one is a graph there where we were looking at what the patients in the focus groups were telling us, that they were sick, that they had other physical complaints, and that they took a lot of care to take care of. And it turns out actually that's related to Medicare. Medicare does cover things related to how sick you are, what other organs are involved, and what kind of services are involved. And we compared what the patients were telling us in support groups and focus groups to what's called the SF-36, short form 36, that is based on actually 2 weeks in Dayton, Ohio in 1974 as a midsection of America. And if you look at what the patients are telling us and you correspond it to things like physical functioning, body pain, social functioning, and general health, there's a very strong correlation with body pain, also strong with social function and mental function, not as much with general health, interestingly. And this is work that we use currently and that we published last year. So using these focus groups, one thing that's been obvious to most of my colleagues is that a team approach is crucial for helping patients. And just as there are other areas such as the autonomic nervous system as part of the illness, many things that are not GI tract are involved. My observation is that providers often underestimate the effect of the illness on the patient's quality of life, and that increased levels of anxiety and depression in some patients, which are known and reported, may likely be due to the trauma of the illness itself. Unfortunately, physicians are sometimes taught to say, well, gee, the patient's anxious and depressed, so that must be the cause of their problems, but that's not what the data shows. And even well-intentioned providers may make things worse sometimes. So what's been the response for that nationwide? Well, part of that is the National Institutes of Health Gastroparesis Clinical Research Consortium was set up really in response to patient needs, patients contacting the NIH or their congressman. And I've been fortunate enough to be part of that for the last 11 years. The site is worth looking at, gpcrc.us, not .org, but .us, and they have a section for patients. And I'll talk a little bit about that. I'd also like to mention the Food and Drug Administration, which I think is very helpful, and as patients and have contacted them and companies have come to them, they've tried to define what should be measured and reported. A lot of it's related to what are called patient-reported outcomes. And Medicare is also an issue. Medicare in the past has not covered many home therapies. Some of that's been changed recently, but much more needs to be done. I'd like to talk a little about the NIH GPCRC as a participant. This is not their official word. This is just me as an observer. They've looked at the disease burden, tried to describe it, talk about diagnosis and details of illness, and talk about why it occurs, called pathophysiology. There's also been interaction with the Food and Drug Administration, and I think the profile that's been raised by the GPCRC has been helpful, we hope, in some proposals on Medicare coverage of chronically ill patients, including GI patients. So I'd like to talk a little bit about what's called the gastroparesis-like syndrome, and my colleagues at the Gastroparesis Consortium reported this because we enrolled people based on symptoms, and not everybody had delayed gastric emptying, which is the classic definition of gastroparesis, which I'm not going to talk a lot about today. But the classic definition, if you line up patients who have delayed emptying or non-delayed emptying, they're identical in every respect except for their emptying. And I'll show you, I think, why that is in a minute. So gastric emptying may not be the best way to differentiate patients. And as I mentioned above, these gastroparesis-like disorders may be really almost the same thing. These findings, I think, are very important, as I'll talk about in a minute, about how gastroparesis is viewed. So when we put in gastric stimulators, which I've done a lot of work on, I'm not going to focus on that today, but as we put those in, and other times when patients require surgery, we obtain what are called full-thickness biopsies of the GI tract, where we can look at the nerve and muscle. And related work, particularly from the Gastroparesis Consortium, but others like our team have looked at this over the years. There are measures that are called ICC that doctors may talk about. It stands for interstitial cells of Cajal, C-A-J-A-L. And Ramon E. Cajal was a Spanish neuroanatomists that described them over 100 years ago, and actually won the Nobel Prize in 1908 for this and similar work. And as an aside, if you go back and you can look at nobelprize.org, and you can look at their speech for Cajal, and before, a few years before that, for Dr. Pavlov, they were actually talking about a lot of the illnesses we have today. But as these numbers that are just, I'll show you in a minute, get lower, the emptying becomes delayed. And this is a slide, the only other slide I'll show you. On the one axis here, these are the interstitial cells of Cajal. This is 3 groups: people with delayed emptying, people with nausea, vomiting, but not delayed emptying, and control patients. And this is from work done with the NIH consortium. And on patients that were patients of ours when I was in Mississippi. And these were the control patients from the core lab at the consortium. And you see the normal number of these cells are 5 to 6 from high-powered field. Here's the unexplained nausea, vomiting. It's 3 to 4, and then this, where they're delayed, is around 2. Now I grew up in the Northern Plains, so I'm a kind of a car guy, and I like to use car terms, which at least some of our patients understand. Others may think it's funny that I talk in car terms, but I call these the spark plug wires. So it's like having a 6-cylinder engine with 6 spark plugs, but all of a sudden, if you take away 2 of those wires, things don't function too well, and you see patients can have symptoms without being delayed. And you get down here and you've pulled out 4 of the spark plug wires and you only have 2. Imagine the engine doesn't run well. So this is would imply that it's really a spectrum here. I'm going to editorialize for a second what I tell physicians who say, well, gee, that patient, I know they're vomiting, but their emptying's not delayed, so how sick could they be? To me, it's a little bit like the analogy of heart disease. Let's say you don't get enough blood to your heart and you have angina, and you really don't get enough blood to your heart and you get an MI. Well, I think it's reasonable, personally, to treat with the symptoms before you develop delayed emptying. But that's controversial, and I've told you that that's just my bias. So what does all this mean? So myself and others view these gastroparesis and the gastroparesis-like syndrome as part of a spectrum. And many, particularly outside the U.S., don't agree with us. There's not general consensus. And what I'm going to talk about next is some new work related, NIH-funded work, that these are my opinions only, not anybody else's. But we recently looked through the Diabetes Consortium, another branch of the NIH that I was able to do through the consortium. We looked at a small group of diabetic and non-diabetic patients, and we looked at a lot of things, inflammation, because we were concerned that people were systemically inflamed. We looked at their autonomic nervous system. We looked at, same group, we looked at the enteric nervous system, those full-thickness biopsies and other biopsies. We looked at electrophysiology, the EKG that I've been interested in, and we looked at hormones. And basically, all these were abnormal in this group. So one conclusion, and this is my opinion, is that gastroparesis can be looked at as systemic disease with variable presentations. And this work has all been submitted through the FDA clinicaltrials.gov, but it hasn't yet been published. So we also looked in this study at the mechanisms why this may occur, and I'm going to show several possible mechanisms or talk about those, but I'm not going to emphasize that's really not the purpose of this talk. The rest of this talk is to talk about therapies. And as I've already made my opinion, and my point is that maybe people with gastroparesis have systemic illness. It's not just their stomach, although the stomach may be where their biggest manifestations are. So I'm going to talk about COPS, not to come arrest you, but to help you out. C for care, chronic disease, O for options for therapies, P for particulars, and S for searches. So the chronic illness care, the C's, I call home care, primary care, which is crucial. I'm a former primary care doc myself before I did GI. Internet care, which I think every chronically ill person now has access to the internet, and hopefully you can hear the webinar put that way today. Acute care, which is always difficult when you're chronically ill. Chronic care, which is, I'll talk about in a minute, and hospital care, which can be problematic. But they all need to be integrated, in my opinion, so providers work as a team, and ongoing communication is essential for chronic illness. Now, I don't think that's news to anybody, and particularly chronically ill patients probably couldn't agree more. So I'd like to talk about some of the particulars with therapies. One would be diet, nutritional support. Another would be drugs. Another would be devices. Another would be what I call disrupt and divert. And last, detoxify. And I'll discuss each separately. But first, why are there not more treatment options? And particularly, why are we in this situation where people are symptomatic and still suffering? Well, I think there are a lot of reasons. From my perspective, over the last few decades, I think there's still the belief, and it's a belief, not belief. I'm a very religious person, and beliefs are about religion. I'm talking about data, that people believe the GP is not a real disease, that it's not a biologic problem. But even if they say, well, maybe they are sick, these patients, there's a lack of understanding about the mechanisms. There's limited resources for new drugs, although that's changing. And there's been a narrow view of treatment options. All these, I think, have contributed to our lack of treatments right now for gastroparesis. So let's talk about what we do try to do. First is the diet and nutritional support. And traditionally, people are recommended to have frequent small portion meals of less limited, quote, digestibility, although that may vary patient to patient. The problem is it only works with certain patients, and the majority of gastroparesis patients, unfortunately, are never seen by a nutritionist, even referral centers, including ours. And a lot of this has to do with reimbursement, sadly. The contract for our current center doesn't include gastroparesis patients as having access, and they're not unusual. More on nutritional support. The Oley Foundation, of course, has been a leader in this, and I think everyone knows enteral nutrition is best, but not everyone can eat. And for those that can't eat by mouth, small bowel feeding is an option. We usually try a nasal, abbreviated NJ tube, then a permanent tube. But there are limited expertise of problems with tubes. As patients know, a lot of physicians, even gastroenterologists, aren't comfortable with tubes. They end up in radiology, and people don't always understand. They go to the emergency room, and people don't know what to do if their tube's clogged. So not everyone can have successful small bowel feeds. One editorial of mine is that most people that get a permanent tube never have a small bowel biopsy, which would give us a tremendous amount of information, potentially on nerve and muscle function. And as another side editorial, imagine if one had a cancer and you didn't do a biopsy, you wouldn't know what you're treating. Well, these patients are as sick as people with cancer, and yet we don't do biopsies routinely. So I tell any patient that's going to get a biopsy, a procedure, ask them to do a biopsy. And if their own lab can't handle it, there are a number of regional labs that can do the stains, but the stains are all available. So even more nutritional support. TPN is the only option for some patients, and that's beyond discussion of today's talk. It can be wonderful, life-saving, but it's not easy, it's not inexpensive, and it's not risk-free. And expertise on TPN varies widely. We all have trouble finding providers, but there are excellent TPN pharmacies everywhere, and support groups like Oley help greatly. So what about drugs for gastroparesis? I'd like to talk about by class. One are anti-emetics, another prokinetics, and other. Many are available worldwide, but not in the U.S., and some are investigational. But fortunately, there's a renewed interest by pharmaceutical companies now in the U.S. And elsewhere for drugs for gastroparesis. First are anti-emetic drugs, and I've listed first the chemical name, generic name, and then the brand name in parentheses. But promethazine or Finnegan is the classic one that's used probably the most. Sadly, as some of you know, we've had a shortage of Finnegan, particularly for parenteral use. Much like the cancer chemotherapy drugs that are common ones that there's a shortage of. It's been a really distressing situation for many of our patients. Other drugs like prochlorperazine, compazine can be used. Diphenhydramine or Benadryl can be helpful. Ondansetron, serotonin drugs and other drugs related to ondansetron. Scopolamine, transferrin scopolamine, cholinergic acting drug and Marinol, Drabanol, which is the THC part of marijuana, can be helpful. So those are the commonly used antiemetic drugs. Prokinetic drugs, we have only one approved in the U.S., metoclopramide or Reglan. Many ways to deliver this, PO or enterally, nasally, suppository. There are a number of therapy issues, and short and long-term safety concerns have led to recommendations for short-term use. And it can be of some help, but has the limitations that I just mentioned above. There are other prokinetic drugs, for example, that are on the market but not approved. Aprepitant or Mend is quite expensive but can be very useful. Erythromycin, antibiotic, can be helpful but may not work long-term. There are other drugs that haven't been systematically studied, but that can be useful. We have more to say on drugs for gastroparesis. The investigational drugs not approved in the U.S. include domperidone. It's pretty clearly safer than metoclopramide, but has some risks. And there's some complexity in obtaining that I won't go into today. The investigational drugs in clinical trials are all under FDA guidance, and we appreciate the FDA's interest in trying to help patients. There are even more comments I'd like to make on drugs. Most are tablets, but some are capsules, some are suppositories, some are liquid. Some can be given intravenously, and IV therapies of drugs is really beyond the scope of today's talk. There are real risks, but some have benefits. And coverage issues by insurers, you need a dedicated team. We have, for example, almost 15 people in our office, and we have people who work almost full-time on getting insurance approval. And many offices just don't have the resources to do that. I'd like to discuss drugs for pain because it's a very complex issue, difficult for most patients and providers, and even more so by the understandable discussion of opioids in the country, and making it even harder for gastroparetic patients to get pain relief. One approach, and the approach we use, is for all gastroparetic patients with pain to see a pain specialist, because in part of my life through the International Neurostim Society, as I work with physicians who work heavily with pain, and there isn't any reason pain can't be treated, in my opinion, but it does not often happen in practice. And it's difficult, just as like it's difficult to find people to take care of gastroparesis and nutrition. It's difficult to find people to take care of pain, but we all hope that that will improve in the future. And maybe that will be another webinar for somebody. Devices for gastroparesis have limited availability. There's only one approved device with regulatory insurance and other issues. I'm not going to talk much about it today. I have a lot of experience with this since my team originally arranged for this to be licensed by Medtronic decades ago. But it was approved by compassionate use in 2013, and it can be helpful. I'd like to talk about diverting and disrupting, and by that I mean the stomach has an inlet, upper esophageal sphincter. It has an upper stomach that functions almost separately sometimes from the lower stomach, and it has an outlet. And there's an increased interest in pyloric or outlet function and dysfunction, and clearly this is an issue for many patients with gastroparesis, especially if they have delayed gastric emptying. There are many new approaches, particularly endoscopic approaches, that have gained a lot of understandable, worthwhile publicity. None yet are conclusively shown to always help, however, but I discuss this with all patients and try to give them the information that we have at the time. Now, my last D is detoxify, is that many gastroparetic patients have systemic issues. This is my opinion, but I think there's evidence for it because of not of the generalized symptoms, but disordered physiology. And many of our patients have neuromuscular issues by blood or tissue inflammation. And there are therapies like immunoglobulin, IVIG, or other immune and inflammatory drugs that can be helpful. It's been very difficult to get evidence-based trials funded for this. In fact, we've been unable to do that, but we and others have published now 2 peer-reviewed articles, another one that we hope will be published soon, using IVIG in people that have failed everything else, and so that's a possibility. So what about other particulars for therapy? Well, I think to me this is crucial because I spent my life first as a primary care doc. I did ER, I did hospitalist. I did that to support myself while I was a research fellow for 4 years. And it was, I'm convinced that this is what has to happen. You have to have the patients and you have to have protectors, which usually are their family, but sometimes friends or the community. Then you've got providers, which, as we talked about, most providers were never educated about gastroparesis. Then there's partnerships. A lot of times the insurance companies, which we sometimes view negatively, can be real partners when we point out to them, gee, this patient's costing is not only miserable and costing you $250,000 a year, but maybe there are other ways to treat them that we could work together. The pharmacies and professional companies can be very helpful, particularly in obtaining medications that we can't obtain otherwise, and also for infusion services, much like with parenteral nutrition. And then there's the processes of how we all work together and communicate. Our team, I spend a lot of my day actually texting providers. I joke that I used to have an office, now I just have a cell phone because I get email and text. But the one thing you don't want to do as a primary care doc is have somebody come back in your community after being at a tertiary center and you don't know they're back. So I always try to contact them. And I think having a true team is crucial for any chronic illness. So my last part of COPS, are the searches for the future, not just internet searches, but what I call pre-search, which is talking about the issues like today with these webinars. And research is the formal work, which I want to mention again, the GPCRC was set up because of patient advocacy and the NIH realizing this was the correct thing to do. There's what I call pro-search, which is the education of providers, and one of our goals for the GPCRC and the professional organizations is to educate providers. Primary care providers, emergency room providers, hospitalists, subspecialists who are just not comfortable or familiar about what can be done. And what I call Q-search, how can we get in the future? And I think support groups are crucial. Oley Foundation, I know AGMD and GPAC were also notified by this, but there have been a number of other support groups that I could not exist without. And knowing the federal resources, the NIH, the FDA, Medicare, and others are very important because that's basically us. That's our tax dollars. That's how we support things. So I'd like to make some summary comments, and hopefully we're on time. Summary comments and some conclusions, and then end with some people I'd like to thank, and then how you contact us. So as you probably gathered, I tried to emphasize that most things in medicine are opinions versus facts. And thus I've given my own opinions, not anybody else's. I think over the last 50 years, I see things going from what I viewed as bad to good to or better to mixed to now, which I think is better, even better, and the future. I've tried to focus on therapies, but especially teams and support in the context of illness that we call gastroparesis, which when severe is GI tract failure. Migraine, for example, bad migraine can recur and be associated with every migraine attack. You get deposition of iron in the brainstem, and that causes delayed emptying. So eventually these people may start out with migraine-like illness. They too can become gastroparetic. So my concluding comments, these are my bottom lines. One, gastroparesis has been misunderstood, which is not unusual in the history of medicine. It may take decades or longer for illnesses to be understood. I now think it's accepted as a legitimate illness, although still not everyone agrees. Number three, I think the U.S. NIH, FDA are engaged in work on this problem, and Medicare and government can be lobbied. I mean, everybody that's listening today is a voter and a taxpayer, and it's much better if they lobby than me. When I lobby, they say, well, you're just saying this because you want to take care of patients, and I do want to take care of patients, but it's much better when it comes from patients themselves. I think we've learned a lot about the last decade or two, particularly about gastroparesis and gut failure, but much more work needs to be done, and I see the partnerships of patients, protectors, and providers and processes is the key to making this happen. I'd like to thank a couple of people and have one concluding slide. I'd like to thank first the Oley Foundation for allowing me to talk today, and I'd like to thank the people that trained me and the people I work with today that allowed me to do this. I'd like to thank the funding sources, particularly the NIH. I'd like to thank my family for allowing me to work in this area, but mostly I'd like to thank the patients. Patients sometimes say, thank you for seeing us. I really appreciate that, but really it's thanks to them for how much I've learned from them. So web access is crucial. The GPCRC I mentioned, all the support groups have websites. There's many online sources, including FDA and Medicare. We'll try to answer any and all questions. You have questions for the Oley Foundation. It's Rosalind Dahl, DAHL, r@mail.amc.edu. And we'll try to answer those in a timely manner if we can't answer them all today. So I think according to my clock, I've made it on time. I appreciate everybody's attention and the opportunity to talk today, and I will stop there and turn it over to Rosalind.
Great, thank you so much, Dr. Abell. That was such a wonderful presentation. I know I learned quite a bit there. I am just turning the presentation over to myself to start the Q&A. Just give me a second here. There we go. All right, now you should be seeing my screen.
Yeah.
Okay, so we're going to start the question and answer session right now. I have to say that I haven't received any questions from people that are attending the webinar today. If you are interested in getting a question across, please start typing those in the question section. I'm going to start with a few questions that I received ahead of time from people when they registered. The first question that I received from a registrant was, what can be used to treat the sometimes extreme bloating that occurs with gastroparesis, which does not seem to be caused by gas?
It's a great question, and fortunately, there's been a lot of work on bloating, particularly the distension. Bloating is kind of the feeling. Distension's where you have to loosen your clothes. And one of the people that trained me, a guy named Juan Malagelada, who's now retired, but he was my teacher at Mayo Clinic, and now is back in Spain, where he was from originally. He worked extensively on looking at the redistribution of air in the GI tract, which happens in motility disorders. So a lot of it, I think there's two things. A lot of it we think bloating and distension is because again, things don't get handled properly. The gas gas doesn't get moved through properly. So if that's the case, trying to correct the underlying motility problem is the way to do. It's just, as I said in the discussion, there's not a lot that we have. We have limited options. But the second thing is that sometimes the gas is produced by bacteria, small bowel bacterial overgrowth. So sometimes treating that with antibiotics would be helpful. And as many people are aware, there's a whole new world of what's now called the microbiome. In fact, so much so that people do not talk about the brain and the gut and the microbiome as one whole option. And has the potential to revolutionize much of what we do. So as we learn more about that, antibiotics, sometimes probiotics, can be helpful. Part of that can be determined by doing testing. For example, you can test for bacterial overgrowth, or you can just treat it, what we call empirically, just to treat it. So many of our patients end up combinations of prokinetic drugs or other therapies like stimulation and antibiotics, or prokinetics or probiotics. So I hope that's some answer to that question. Okay,
and Dr. Abell, we did have someone write in that they are sharing that their son has had some good success with, and I'm not sure I'm going to pronounce this right, cyproheptadine.
Yeah.
That it didn't work when he was younger, when he was 5 to 7 years old, but now that he is 12, they are having some success with it. That erythromycin was inconsistent and not frequently effective. So that's one comment from someone. And we also have a couple more questions coming in. One is it possible to have a normal GES, and I guess that's gastric emptying, and still have gastroparesis?
Well, great. Two questions. Let me talk about cyproheptadine. I didn't talk about cyclic vomiting, but that's been my interest for 50 years. And people use cyproheptadine and other agents like that for cyclic vomiting, and it can be helpful. One of the problems is that, as I mentioned in one of the slides, a lot of these drugs haven't been studied systematically in gastroparesis. And so one of the things we're doing with our consortium is trying to study some of these what's called evidence-based medicine trials that we can try to sort out who it's helpful for and why. So I'm glad that question was put in. The other question about can you have gastroparesis and have normal emptying? Well, I tried to show a slide about that. It gets the question of definition. If you define delayed gastroparesis as being delayed emptying, then you could say, well, you have normal emptying, you don't have it. But that's why we came up with this term collectively. It's called many things: unexplained nausea, vomiting, or gastroparesis-like, where it's also pretty clear you can have damage to the enteric nervous system. You just don't have enough damage to be delayed, so you still have symptoms. So I call them gastroparesis syndromes, meaning nausea, vomiting, whether they're delayed or not. A lot of my colleagues wouldn't agree with me on that definition, but that's the way I look at it.
Okay. Great. Now we're getting quite a few more questions. So the next one is, could you expand upon dietary modifications / recommendations for gastroparesis?
Sure. It should be a talk by itself, and probably by someone other than myself. But it's fascinating to me. There's some people that can tolerate certain foods that the next patient I see can't tolerate at all, and yet we think of them as the same. So a lot of it, sadly, is trial and error. But there are, again, in terms of bloating and distension, there are some people that respond to what are called low FODMAP diets, things that are fermentable sugars and other foods in the gut. So we often, for bloating, and I didn't mention that earlier, under the microbiome, we often try the low FODMAP diets, so that can be helpful. The other aspect that I referred to is and it's a failure, I think, of our medical care system, that we don't have more nutritional input, and a lot of it has to do with reimbursement. Even in our consortium, the vast majority of patients were never seen by a nutritionist, and they have so much knowledge. I think it's several things. I think working with the physician and the team, which includes the nutritionist, for a given patient to try to see what foods can be eliminated that might be offensive or harmful or hurt them in the sense of symptoms. Most foods don't obviously hurt you, but in terms of symptoms, and then trying to get expert nutritional help, because it's out there, just most patients don't have access to it.
Okay, great. And just so listeners know, on the diet page on the Oley website, there are some articles about diet, and one of them includes a discussion of those FODMAPs that Dr. Abell was discussing. Another question that we have is for you, Dr. Abell, is that are there centers that have specialties in gastroparesis?
I guess there's two ways you could answer that. Are there specialized gastroparesis centers, which there are, or are there within those centers, are there people that specialize in one thing or another, which there are? So either way that question was intended, the answer would be yes. There are not a lot of centers. There are not a lot of people trained in motility, and not everybody that's trained in motility actively sees patients. But some of them do research in academics and other things more than they see patients, and that's fine. It's just when you're a patient, you want to be able to see somebody. So there are gastroparetic centers, and then within those centers there's some variation. That's one strength of our consortium, is we try to share our expertise. But yes, there are centers.
Okay, great. Another person is asking, what is considered short-term use for Reglan?
Well, I don't have the labeling pulled up in front of me, but I think most people recommend not using it more than a couple months or 6 to 8 weeks. I see people that have been on it for a long time, and there are real risks with that, with what I call late effects, tardive or late dyskinesias, movement disorders that really have essentially been untreated, although there was recently a drug approved for that. But because it works centrally, it has advantage of working centrally, but it has a drawback of having some central side effects. So we try to get people off that on safer drugs, but the problem is their safer drugs are either non-existent or hard to get, and that's the reality.
Okay, the next question is asking, do you see pancreatitis as a symptom of gastroparesis? This person who wrote in has said they've had it 11 times.
Yes, and I probably should have mentioned that. That's been one of my interests. And if you talk, pancreatitis, usually people think, well, gee, most of us, those of us in GI, it's alcohol-induced or gallstone-induced. Mm-hmm. But there are lots of people with motility disorders have recurrent pancreatitis, and if you talk to any major pancreatitis center, they'll tell you they have a lot of those patients. And I don't know that we quite understand the reason for that. I think that some of it is to do with the fact that gastroparesis is associated with decreased pancreatic output, so there are pancreatic abnormalities. I know that because I've published work in that on pancreas, and also I'm involved here in a pancreas transplant program and also islet cell program. So I see a large number of patients that have recurrent pancreatitis and gastroparesis and never drank alcohol or never had a gallstone. So it definitely exists, and it's probably under-recognized, under-reported, and thus doesn't get treated optimally.
Okay. The next question is, how can someone who has gastroparesis syndrome due to Ehlers-Danlos and mast cell activation best be treated? Will Medicare and private insurance pay for IVIG therapy to help reduce mast cell-induced inflammation in the digestive system that reduces motility and contributes early satiety?
Yeah, great question. Yeah, satiety. There's really, if I could try to answer the 2 or 3 questions there. One is Ehlers-Danlos, another is mast cell activation, and another is IVIG and coverage. So let me try to cover them separately. Ehlers-Danlos is much more prevalent than people thought. There's at least 6 or 7 types. The one we see more in GI when we recognize it is Ehlers-Danlos type 3, which unfortunately there's no good biologic test for. It's a clinical diagnosis. There are a couple centers set up, the worldwide, the one in London, Dr. Aziz, A-Z-Z-I-Z, and has published, but others have published on this. And when we had a recent NORD, meeting, National Organization for Rare Disease meeting, I didn't mention them, another very great support group. The Ehlers-Danlos people had a display there at the NORD meeting this year in Kentucky, and a lot of them have GI symptoms, so it's very important. Mast cell activation may or may not be associated with Ehlers-Danlos in a given patient, but mast cell activation syndromes are well described. And actually, Pavlov, who I mentioned, and Golgi and Cajal, they were concerned about, they speculated that mast cells over 100 years ago were part of the problem. And there's a lot of evidence that disorders like irritable bowel syndrome involve mast cells. When you have a real marked predominance of mast cells, you can get active inflammation, and IVIG, in our anecdotal experience, observational experience, is helpful. In terms of coverage for Medicare, I don't know. We have, I don't know what our average length of time of getting IVIG approved is, but it can be 6 or 12 months sometimes for us to get it approved, and we just keep, it's off-label, like much of what we do. We just keep sending in letters, phone calls, talking to them, whatever it takes. So I tried to answer that as 3 or 4 separate things.
Right, you did a great job, Dr. Abell. The questions keep coming, so here's your next one. What antibiotics specifically do you use for bacterial overgrowth?
Probably the one we use more than anything these days is Xifaxan, rifaximin, because it's a little easier to take, although it's not cheap, and it's not approved in most cases for bacterial overgrowth per se. although it's getting approved for more and more things all the time. But you can use any number of antibiotics, broad spectrum. But the nice thing about rifaximin, as the generic name, is it's basically non-absorbed systemically, so you don't have to worry about getting antibiotic resistance and things. So that's probably the one we use the most.
Okay. We have another person asking whether you still see patients.
I do. My clinic, even though I'm 69, I'm sure at some point that will change, but it hasn't changed yet. And we have this is not to publicize us, but I do, and we have a center here with 3 or 4 providers and about 10 support staff, and all the NIH consortium centers have gastroparesis centers, and then a number of other centers in the country see patients. So one of the problems is so many. I did a survey that's not published yet, but where we looked at how many people were told they couldn't be helped and how many people were told no one would see them, and the numbers are, when it gets published, are astounding. We compared that against other diseases like chronic liver disease, and a lot of times I'd say I can't help you, I'm going to sit in a liver center, but they didn't say you can't be helped, and that is sadly still occurs, making the disease burden even broader, because if people weren't already anxious and depressed and then they realize they can't get anybody to take care of them or anybody close to take care of them, it's even more distressing.
Yeah,
but I do think with the help of the support groups, we're making progress. Yeah,
Dr. Abell, I would reiterate that we get an awful lot of calls that are patients who really, it's hard to get a specialist and to find someone who will respond, and we're very grateful that you're sharing your expertise today as you are. As a matter of fact, that's how the next question starts out. It said, we'd like to thank you, Dr. Abell, for your support. This person says that they don't have any support where they are locally, and they are thankful for, thank you for your support from all of us where headaches are common. She is asking, what's the biopsy you recommended earlier in your presentation?
Sure. Well, I appreciate that. And one of the great things about a lot of the great things about the internet, I mean, I know there's some drawbacks, but is that patients can be anywhere and hopefully not feel alone. It's just it's wonderful, and I think literally sometimes life-saving. Regarding the biopsies, the problem with getting there are 2 problems. One is to really look what's going on in the gut. You need the full thickness. There's the mucosa and the lining of the mucosa. It's called submucosa, and then there's the muscle layers and the nerves in between. And to do that, you need a full thickness piece. Now, as an aside, I have a lot of colleagues who are working on ways to do that through endoscopic ultrasound or other ways. So hopefully there will be, but it's not widely available. So what I'm talking about is getting a full thickness piece. If somebody's having any surgery, like J2 gastric stimulator, where it's possible for the surgeon to just go in there and do a full thickness biopsy, I think that's useful information. And or if they've ever had like a colectomy, if I see somebody that's had it, usually those samples, the tissue is still in the lab in the slides and can be obtained and sent to one of the reference labs. And that can be very helpful because it makes a big difference. For example, if somebody has a muscle involvement or the nerve involvement or both, it could literally change what we do. So I think it's been one of the more exciting things from the consortium is the work that's come out of that.
Great. The next question is, why do some patients gain weight with gastroparesis while other patients lose weight?
It's a wonderful question, and I should have mentioned so many things, including that. I think when I started working in this area 30, 40 years ago, most people were underweight. We have there's 2 things or 3. One is we have better nutritional support, but the problem is it's a little bit uneven. For example, you can gain weight, which is good, but it isn't always the same as being able to eat normally. And so sometimes you gain more weight than you'd like. The second thing is that diets are so restricted, we used the food frequency questionnaire, which is a standardized questionnaire, and looked at the average diet in our gastroparesis, and this is published by us in the consortium, and 83% were carbohydrates of the diet, because that's all they can eat. They can't digest protein, they can't handle fats, and so when you eat only 83% carbohydrate, guess what? You're gonna gain weight. And the third factor, I think, is that the hormones, even if you're not diabetic, it looks like from our data and other people, the glucose-related hormones, metabolic hormones like glucagon, insulin, and one called amylin, it's co-secreted with insulin. Those are abnormal, and when you get a metabolic abnormality, you can gain weight. We see it in people with type 2 diabetes, for example. So I think there are a lot of reasons, and actually it's a real problem because people will say, gee, they don't look sick to me. They're gained weight, and it's very distressing for the patients because it's like they're vomiting and yet they're gaining weight. How could this happen? On the other hand, some people aren't able to even take in enough nutrients to sustain or gain weight, and they lose weight. And being overweight is the problem. Being underweight is the problem. Obviously, ideal weight is where we want everyone to be. But I think we've got a better understanding than we did 10 years ago.
Okay. The next person is asking, can back or spine issues such as severe osteoporosis cause gastroparesis?
Well, I don't know if it does directly, but I certainly see people that have spine injuries. Let me give you an extreme example. I work in my building's in a thing called the Fraser Rehab Center. That's a big spinal cord unit, and spinal cord injury is associated with the colon not working, but it's associated, depending where the level of injury is, with the stomach not working. So clearly, severe injury can, and I don't think there's any reason to think that less severe injury wouldn't also. Anything that involves disrupting the nervous system can have an effect on what we call the enteric nervous system, because the body is like one big wiring harness. Everything is connected. If you blow up something in a balloon in your rectum, it shows up all the way along the tract, and a little light goes off in the brain. That's why you feel it. It's all connected. So yeah, it can be. I'm not a neurosurgeon. I'm not a neurologist, so I can't always tell you exactly on a given patient how that would happen. But yes, it could be associated.
Okay. The next question is whether the gastric sleeve and the gastric bypass surgeries are ever good treatment options for patients with gastroparesis.
Well, it's hard to know. I've reviewed this data. I'm very interested in it. There's no control data. There's one. I'm aware of one series with the sleeve from Columbia, and I know the surgeon that did it. She's very nice. But it was not a controlled study. I've seen a few people anecdotally that seem to be helpful, but I also see a large number of people that have it, and it either doesn't help them or makes them worse. We just don't have the data to say. Because of that, I don't recommend it as a treatment for gastroparesis. But I have seen. I've understood there are some patients that's been helpful for. I haven't seen them, and I don't have the data to support it. So that's all I can say is what I know, or from personal experience or data.
Right. Dr. Abell, this is going to be the last question. Are there any research or approvals by states for the use of marijuana to help for patients with gastroparesis?
Boy, I don't know. I'm not up on that. You probably literally could do a net search, Google that, because there's so much activity now with marijuana, depending on the states, and particularly those that have approved it for medical. And there's I get emails from the organizations, all the time wanting to submit data and things. I don't have any experience with that.
Okay.
But I bet the knowledge is probably out there, though.
All right. Well, we're running out of time here, so we're going to end the questions and answers section. This is the main resource page on the Oley website for motility disorder information. In case you're having trouble reading it, it's oley.org/motility information. And then I would like to thank Dr. Abell for your wonderful presentation and all the questions you were able to answer. You were a stellar presenter. We are so appreciative of you sharing your expertise today and for sharing your expertise in your clinic. Thank you, thank you, thank you for taking care of our members. I'd also like to thank Shire for supporting this important educational program and to thank the participants for joining us. I'm going to remind you that we're posting a recording of this presentation on the Oley website in case you'd like to view it again. Again, that address is oley.org/webinars. It's right there in the middle of the screen. Hopefully you can see my cursor underlining it. We hope you'll also join us for another webinar down the road. We'll be taking a hiatus this summer, but later this fall we'll start the series up again. And lastly, I'd like to invite you to join us at the Oley Annual Conference, which will be held July 5th to 8th in Old Greenwich, Connecticut. We'll be having another motility disorder specialist speaking there, Dr. Richard McCollum. He will be speaking on July 7th. Information on the annual conference can be found at www.oley.org. The registration is free, and there are a wealth of other opportunities at the conference besides seeing Dr. McCollum. There are talks all about nutrition support, about coping, about, just so many different topics. I can't even cover the gamut today, but you can see an overview of the program and all kinds of things like that at, again, www.oley.org. That'll be it for today. Thanks again, Dr. Abell, and thank you for everybody for joining. Take care. Bye-bye.